Oh, but want to welcome you and thank you for joining tonight for the AHP Clinical Grand Rounds. We have three speakers tonight. Our first two are going to present together on the topic of updates to pediatric asthma assessment and treatment. And our speakers for that are Bob Adams, who is our Director of Pharmacy Services at Accountable Health Partners and part of the broader pharmacy team across URMC and its affiliates. Bob has been with AHP about a year and a half now. And prior to that, he spent 15 years with the pharmacy department at Rochester Regional Health, serving as the Assistant Director of Pharmacy, Director of Pharmacy at Unity Hospital. And he has lived in Rochester now for nearly 30 years. So a true Rochesterian living on the west side in Spencerport, New York, with his wife, Jen, and their 4 kids, who he reminds me are all middle schoolers and high schoolers. So Bob is a very busy person. And then we have Paul Tremblay, who's presenting with Bob. Paul is currently nurse lead for community-based asthma care management and program development in the Pediatric Health Services Research Group at the University of Rochester Medical Center. He's a registered nurse and a certified asthma educator, and Paul has worked with Dr. Jill Halterman since 2006 to coordinate the testing of interventions intended to improve systems of care for youth, primarily focused on practice guideline implementation and connecting school nurses, telemedicine, and nurse home visits to existing care structures. Paul also has served in a variety of nursing settings responsive to those underserved, everything from working with those with Alzheimer's disease and dementia, working at the St. Joseph's Center as a part of the Catholic Worker Soup Kitchen. And he continues to very passionately pursue community engaged solutions. He also has called Rochester his home for 30 years, lives in the Highland Park neighborhood with his wife, Jennifer, and has 2 remarkable sons in the RCSD School of the Arts. So I'm going to turn it over to them. And then when we finish, I will introduce our third speaker and our third talk. So feel free to share your slides and we'll go forward.
Great. Can you guys all hear me okay? And can you see my screen? All right. Well, thank you, LJ, for that warm welcome. And it's really great to be able to take this opportunity to talk with you all about pediatric asthma care guidelines and assessing severity and control. And Paul and I are just going to tag team this. And so we'll get started.
Yeah, so we we'll look at the guidelines. There's the NAEPP is the NIH's National Asthma Education Prevention Program guidelines, and the GINA is the Global Initiative for Asthma Evidence-Based Strategy. And then we'll quickly review asthma severity and control assessment, the history, and
can
you hear me okay?
All right, you want me to only, Charlie?
I just need for folks to just mute themselves.
And where we are with that. And then using ICS's LABO's combination and the single maintenance and reliever therapy approach. So next slide. Thanks, Bob. And thanks, everyone. So there are a number of evidence-based guidelines. My work has been with Dr. Jill Halterman to apply lessons learned and improve asthma care outcomes for the children primarily that benefit the least from the care that's available to them, and that they're not able to access and improve their outcomes. So we're trying to work around systems of care. So the NAEPP, the NIH guidelines, were last fully updated in 2007, which is a long time ago. In 2020, the focus updates addressed 6 different content areas. And then what's happened and what's referenced more often of late is the GINA strategy. So GINA, the Global Initiative for Asthma, is updated annually. It reflects expert consensus and global trials done outside the US and evidence developed outside the US more often than the NIH refers to, and it's less rigorous with relying on randomized trials. Both guidelines are concerned with assessment, the impairment and risk domains. So both mirror the criteria for that, and both recommend a stepwise approach. So next slide. Thanks, Bob. So in 2016, the Quad AI and the National Association of School Nurses gathered experts around school-based asthma care and put together this SAMPRO toolkit. So it's the School Asthma, Allergy, and Anaphylaxis Management Program. It highlights the role that schools can play in complementing the care that medical practices are delivering, and asks us as clinicians and providers to think about the nurse being almost an extension of the care, the medical care we want to engage families in. And we've used that principle, and we were invited to be part of this as part of our school-based intervention. So next slide. So this is with each iteration, the criteria for control becomes tighter. So there's a lower tolerance for symptoms and a lower threshold for what good control looks like. And that's because we have more evidence, we understand asthma better, the therapies have improved, and we know we can get children and adults often to a point where they're not experiencing impairment and they're not having the acuity that we've known in the past. So the assessment criteria, both guidelines look at the past 4 weeks. They ask about daytime symptoms more than twice a week. They ask about any nighttime awakening due to asthma, quick and twice a week, and symptom limit or activity limitation due to asthma. The risk domain is also important to consider. So looking at acuity in the past year as a predictor for future acuity. And then so look at this as I'm talking this through. It's important to note, like, many of the patients that we're most concerned about in our practice are the ones that experience a lot of these risk factors. So, and the evidence really suggests that these risk factors and acuity, so need for ED visits, hospitalizations, and systemic steroids, are a marker for concern. And even if patients have few symptoms in between the exacerbations, there are many opportunities to prevent the acuity. So, and also, so we, for our asthma studies, the past few years at least, we're enrolling moderate or severe persistent children and adolescents that are not well controlled. We ask the parents, as we assess asthma for inclusion in the intervention trials a number of ways. We asked the asthma control test, which was developed in 2004, so long ago, before the guidelines had been updated. We ask about a 14-day symptom continuous measure. We ask the NHLBI criteria, which are more involved, and we ask the GINA questions. And often the older versions of the guidelines miss children that are eligible. And we also, so the older version of the NIH guidelines. And we also have, after we enroll participants or add enrollment, we ask the parents if they feel on a Likert scale their child's asthma is well controlled. And the large majority tell us their child is well controlled, they're very well controlled. And we dig a little further, and they often tell us that it's because I give them albuterol when they have symptoms and they take systemic steroids when they have exacerbations. That's how we control their asthma. So, so that'll relate to what we do later. So if you go to the next slide, this is, yeah, so the EPR3, the NIH guidelines are quite involved. Again, the same impairment and risk criteria, but there's different categories for 0 to 4, 5 to 11, and 12 and older. So different criteria within those categories. And then there's different evaluation depending on whether you're assessing severity or control. So GINA really recommends simple yes/no questions. And this is a way, I think, so basically any yes means that there is something that could be done or could be considered to improve the child or the adult's asthma control. So we're looking for none of these to be happening for the child or the adult. And again, if there's one or two, we should probe a little further, assess further, and really think about what could be helpful. And then uncontrolled is there as well. So this is from the Global Initiative for Asthma from 2022. They were updated in 2023, but really it's very similar to this. So if you go to the next slide.
And what we kind of like about, these 5 questions too, is that they're simple, they're kind of unassuming. They don't sort of, make the patient or the parent feel like they're not taking care of their child's asthma. It's just a way that's very easy to kind of assess where they're landing in kind of a non-judgmental way. And so that, and it really kind of, we think, helps to change the story and narrative a little bit, to kind of focus on, we really want people to not have asthma symptoms, and we want to get away from that. I have asthma, so I just live with my symptoms, and I use my inhaler when I have trouble breathing and things like that. So we felt like these kinds of simpler questions really kind of helps to change the narrative for patients, providers, and parents.
And this, we'll get at what Bob's going to talk about next. So this oral corticosteroids, so systemic steroid stewardship statement, was put together in 2018. And it really asked us to think about managing exacerbations and preventing them, so preventive care, in a different way, and looks at systemic steroid overuse as a treatment plan failure, so preventive care failure. And I think where the next thing we may see is albuterol overuse. So SABA overuse also, I think, is a preventive care treatment plan failure. I think the guidelines and the evidence asks us to be thinking that way. So routinely needing more short-acting beta agonists more than twice a week is not a way to manage asthma preventively and get kids to the optimal lung function. And we want to prevent their airway remodeling. We want to prevent adult airway impairment and lung function impairment by addressing the chronic inflammation that underlies the symptoms and drives the acuity. So, all right, next slide.
And so we have all these options, right? And so this is kind of a big eye chart. And what we really want to take away from this is that, it's likely now, with the way the guidelines have been changing, that they're now recommend many patients may be prescribed and will likely be well controlled by using a simpler method, by just going with a single inhaled corticosteroid and a LABA inhaler, budesonide formoterol. And so we're going to kind of talk a little bit about that smart therapy. And, smart therapy is single maintenance and reliever therapy. Gina is leading the charge in this space. Starting in 2019, they acknowledge that SABA overuse and ICS underuse are the chief drivers for poor outcomes, including hospitalization and death. And albuterol and SABAs have been around for 50 years, and it's all the way along, it's been acknowledged that overuse leads to exacerbations. And so why not treat with SABA alone? So this is in 2019 is when Gina kind of came out with this information. The increased use of SABA increases the airway hyperresponsiveness. This leads to a vicious cycle of overuse while ignoring the underlying inflammatory situation that is likely happening all the way along. And it's that tricky, slippery slope that, when is it just an allergy or a trigger that's causing asthma? When is it starting to have asthma because you have an underlying inflammatory response? And also too, it kind of sets the patients up to, feel like the SABA is their rescue device. It's the one that they need. They feel the response when they use it, whereas the ICS, they don't feel that response. And so the compliance for using inhaled corticosteroids dies down because they just don't feel the relief from that. It's not immediate, it's not tangible. So again, budesonide formoterol, Symbicort is kind of like the hallmark of this kind of therapy, and the NAEPP, they also went along with this and suggested that it was a good option for patients. There's no difference in documentation of harm between smart and regular therapy approaches. And this is an old kind of picture from 2008 that kind of represents this idea has been around for quite a while. It's just it hasn't been taken up recently. So the National Heart, Lung, and Blood Institute's original guidelines were released in 2007, and it was a focus update was released in 2020. Now, even though not fully updated in 2020, they still support smart therapy and the move toward tighter controls of symptoms. And that's really kind of what we really want people to go home with and think about, is that, are we doing the best we can for our asthma patients? Are we allowing parents to have their kids live with symptoms? And is there more that could be done for them? So the move toward using smart therapy, and now Brana as a generic of Symcort's out, and we did talk with our Excellus counterparts, and in the commercial space, this is going to become tier 1 available as generic coverage for their patients after 1/1/24, but also whenever plans tip over, when they'll be covered as well. We did reach out to New York State Medicaid to find out how they were going to handle Brana and where they're at with that. And it's still on formulary, it's available, you can use it, but they're still using Symbicort as their preferred product in this space. And that's largely part of the hand over generic program. And what we really wanted to kind of land on and take home is Gina has really been the force that's been moving the therapy and the idea forward more than any other organization. And really for them, 12 years and up, they don't see at all as a good solution for their patients. And so that, even in 1 and 2, they recommend using a combination product with smart therapy. The effectiveness of the treatment not only depends on, or the effectiveness of the treatment not only depends on the efficacy of the patient's acceptance and compliance. And having one device, it's pretty common in many studies that have looked at patients, how they feel about having their devices, how they handle their asthma. They want to use one device. They don't want to have 2 devices. And so this is why, again, simplifying the regimen down is very helpful for them. Now, Paul and I, there's a lot of information here, and we know that a lot of this data came out in 2020, which was in the height of COVID. So we're just trying to help get the message out. So we'll release this presentation out afterward, and it's full of links, and we have lots of references of studies to help you. And we're happy to be available for any questions and come out to your practices and talk more about this.
I want to thank Bob and Paul for their presentation. We have a moment if there are, he really doesn't need an introduction, but he gets one anyway. So Dr. Steve Cook, who is trained in med peds and then was a chief resident in pediatrics in Buffalo, completed his academic pediatric fellowship here in Rochester with a focus on cardiovascular risk factors in children and adolescents. He has conducted community level research on nutrition and physical activity, and many of those community participatory research work with those of you who are here in this Zoom room. He's an associate professor in the Department of Pediatrics and the Department of Internal Medicine, and he has led QI training programs around obesity in our region and across the state for almost 15 years. In 2013, he directed his work to clinical and behavioral treatment strategies to address obesity. He was part of the inaugural board of directors for the American Board of Obesity Medicine and is ABOM certified. He has served on safety monitoring boards for drug studies in pediatric patients in the past and has since worked with the AAP's Institute for Healthy Childhood Weight for their clinical training programs. He's collaborated with national experts with funding from the NIH and PCORI to deliver family-based treatment approaches in primary care practices in Rochester, and with collaborators in Buffalo, St. Louis, Missouri, Baton Rouge, and New Orleans, Louisiana. He has been involved with research and implementation work at the national level with the AAP and other children's hospitals. And I know he's been in Rochester for a long time. I don't know if it's 30 years, but I'm going to say it's a long time. And he has 3 lovely daughters and a lovely wife. Even though he didn't share that in his little bio he gave to me, but I know that for a fact. Steve's going to talk to us tonight about the new.
But if you do it tomorrow, I won't actually be around to eat it.
Oh, we just need everybody to mute. Such a tricky thing in here. The new pediatric obesity guidelines. Thanks, Steve.
Excellent. I hope everyone can see my slides and can hear me adequately. I think there's some nods, so that looks good. Thanks, LJ. So we're really tight on these time, and I was struggling with how much to try to put in here. So I want to keep it just to the guidelines right now and the ideas of what we can do first, because there's a lot in here. And what I really want to try to emphasize is that, we don't have to boil the ocean. We don't have to do it all at once. And I've been here 20 years trying to do this, and I feel the pressure from docs in the community of trying to do something, but we need to just be a little more patient to get some of these services in place. So I want to make sure I have, wait, there we go, forward my slides here. I want to just put these on here just to give a sense that I've actually been involved in some of the drug studies that have tested liraglutide, have tested metformin in kids. Metformin was actually kids with special healthcare needs and autism. I was involved with some studies looking at rhythm with rhythm pharmaceuticals and a drug called setmelanotide, which has been designated for a specific form of obesity and is actually approved. I am not a consultant or getting paid by any of these companies right now. I've been doing this work in the past. So I've seen kind of how it's emerged, and really the insight of seeing how they have to run a study and getting kids to take a drug like this is a lot more than what we do in our practice. So I say that because the guidelines got a lot of attention around surgery and drugs, and the reality is that's a fraction of what should be considered. The guidelines first came out in '97. A small group listed here represented about 20 organizations, institutes had a meeting for 2 days and wrote a pretty simple guideline. And that was kind of what we had until about 2006, when an expert committee came together and put together expert panel recommendation, including all the organizations listed here. And that guideline had a little more meat to it, and actually was a basis of what we used for our first learning collaborative in the Rochester community. And we did that over about 4 years with 20 practices in the county, and gave me a great opportunity to meet so many of you and work with your teams. That's helped us down the road many times in work that we've continued to do. And these guidelines actually had 4 key documents in here around treatment, prevention, screening, and the AAP current guidelines are very similar. So in 2017, as I was finishing up some work with the American Academy of Pediatrics at their institute, we started to put together an idea of this writing panel. They were working with CDC to get some funding to support it, and we put together a review team. It was an external review team that pulled down questions and literature and did a gigantic search. Then they put together subcommittees to review it. And then they broke it into specific topic areas. They created their evidence and grading system. Then it was internally reviewed through all the channels at the AAP, which is extensive, as well as external reviewers that, essentially to sign off on it, which include the CDC, which can take a long time to get their sign off. So these guidelines were originally planned to come out in like October of 2022 and got delayed by CDC, didn't come out until January. So that's the history, which I think is critical because it essentially was almost a 5-year process. But what happens in 5 years? Other things come up, and I think that's where some of the confusion or some of the discussion has arisen. So what do we look like? And you people probably have a good sense of this because you're in the offices every day like I am. This is actually data from the RIO that was collected over 10 counties, and about 21% of kids are at the 95th percentile, a cutoff for obesity. And in that data, they're able to break it down by Black, White, Asian, and Hispanic. We have always had a good way to look at data in our region, and we are very similar to what the national rates are, both overall rates of diseases in kids as well as demographic distribution. So if about 6,000 kids in our region would be at severe obesity, which is 120%, that's probably 9,000 kids. And so I bring that out not to say that we have to treat all these kids, but if we're going to start, we're going to have to start at the tip of the iceberg and work our way down. And that means, looking at getting the right services in place for those most in need, but at the same time trying to train and get some tools out for docs in the community. So the main areas around treatment involve looking at primary prevention, looking at treatment and evaluating children. And this is part of the inclusion criteria for all the studies they looked at, and there was 215. They then looked at additional studies for comorbidities. So there's treatment as well as comorbidities, comorbid conditions, which included things like high blood pressure, liver function, asthma, depression, sleep apnea. And there was 167 studies. And the panel put together, and this is a similar model that I've seen from American Heart Association and other professional organizations, of grading evidence in terms of level 1 or level A, B, C, and D. Are there strong recommendations or moderate in the middle? And then is there a weak recommendation because of a balance between benefit and harm? And so in the guidelines, when you look at them, there are areas flagged as strong and some as moderate. And I don't want you to have to go through all of it, but there are long documents. The AAP webpage actually has a number of resources on their webpage that I'll show you that has really nicely printed out these materials for use in the office. And they'll have a copy of my slides after this. There was the 13 KAS key action statements, as well as 11 consensus recommendations in the areas of assessment, evaluation, comorbidities, and looking at multiple evidence-based treatment options. This is more my slide. So a good portion of these slides are actually from the writing panel team at the AAP. And this is where our experience working with practices, working with you all, doing these family-based interventions, and looking at what is emerging, because the mental health crisis we're in, the issues that we have, so many of our kids are struggling with in school, with self-esteem, with depression, isolation, all those things. We got to really keep this in mind. Obesity is really complex, and we all have biases. And what's really important is we cannot use stigmatizing language, even when we don't think we are, and understand that this is not a choice. There is a biology to obesity that has really expanded over the past 15 years. The problem is it's not in medical school mainstream curriculum at most medical schools. I've talked with the University of Rochester about this with their adult endocrine team, and they agree, and they're very frustrated because there's a small component over like 2.5, 3 lectures that kind of covers obesity. And so it's very easy for medical students to think, and our trainees to think, that it's just about eat less, move more. I mean, there's a tremendous biology that we've learned, and a lot of this is biology in the brain. So keeping this in mind, be aware of mental health concerns and addressing these things first. Asking about social determinants of health. I mean, these are all things that you do for any of your patients with chronic disease. Try to promote positive body image. I mean, this is really important. It's not how the patient looks or feels, and the changes that they may or may not experience isn't about how they look or appear, or will their clothes fit better, or anything like that. If you hear a lot of body language talk, that should raise your red flag that there's a lot more shape and weight concerns. No shaming language, no teasing, even from family. And so it's really important, because parents will pass off their experiences onto their children and blame their children. And that's a point where, just like if a parent is yelling at their kid for not taking their inhaler in the office, you would want to step in and say, hey, listen, this is a team event, and this isn't this isn't just as simple as they have to do better. There's a very complex biology to this. And one thing that's really important is ask permission to discuss weight. Some of you may have heard this from me. This is in the AAP guidelines. I'm trying to simplify it a little bit, because in a patient-centered approach, and when you see patient-centered, that is, all right, can we address this? When your child's having an acute asthma attack, you're panicked, the parents panic, they come in, they want something done now. This does not present that way. Neither does hypertension, neither does high cholesterol. So in pediatrics and in pediatric populations, we don't have a familiarity. And so our impatience of, we got to address this, we really have to temper that. So ask permission. Is it okay if we talk about your child's growth and weight? And if they say no, move on. And if they say no, move on. You're not going to win them over. You're not going to badger them. And actually, the more you push, the more weight bias and stigma they're experiencing, because they are saying, let me go, doc. This is not a good time. This is not a good thing. And if you don't let go, you're actually potentially making it worse. And I just can't emphasize that enough, because in doing these behavior therapy sessions, these interventions, we're hearing that at times. So, and we're hearing that from all our study sites across America. So it's just really important to keep in mind. Ask the parents, if there is a term they prefer to use. Ask the child, can we call it high weight? I wouldn't even say unhealthy weight, because some kids might have a high weight, but they don't have any obvious mechanical or metabolic abnormalities. And that may be an area where we don't really need to intervene right away. So again, this is not crystal clear and clean. One of the big things with these guidelines is that the intent was to say, actually, we need to have something available. And actually, by the AAP having this as a clinical practice guideline, it at least tips the scales to now for the insurance companies to no longer say, well, it's personal choice. It's a cosmetic issue. So I think my camera froze. Oh no, I'm back now. Good. Here we go. So from the AAP, we understand more fully it's the implications of obesity as a chronic disease. It's not an episode. It's not going to go away. And as we see these, impressive drug studies, but just like hypertension, just like, asthma, if a kid is well maintained on their inhaler and they stop their inhaler, good chance the symptoms will come back. These really effective drugs that we are still developing and working on, and newer ones in the pipeline, you stop taking them, the triggers that caused weight to improve, whether it was satiety, hunger, fullness, those are going to come back. Now, for some people, it may come back slowly. Some people, kids and adults, may come back raging. And that's really scary. If you have a child or a young adult who's on a medication and they miss a couple doses, and all of a sudden their brain starts to reset really quickly. Understanding social determinants of health, understanding weight bias and stigma, the language we use, the way we make families, asking them, weight can't be how they're identified, and can't be part of how we discuss any of their health issues, just keeping this in mind. This line, there's no benefit to watchful waiting, came up from the AAP, and really the idea was, for years, it had been kind of taught and proposed to pediatricians, to families, like, well, they'll just kind of grow out of it. And the idea was, we really shouldn't just think that. So a lot of these guidelines have the word should in them, but it's not, should is not must. And you'll see this come up. So it's a matter of saying, what are some of the things we can start with? And we should at least, again, in a respectful way, being aware of the social determinant situation in the home. I mean, you may have a child who's well above 95th percentile, but if parents lost a job and they actually ask about getting some assistance with food, bringing up high weight levels and trying to address that, really, it's not the right time. And so we really just kind of have to slow our roll when it comes to that. Multiple evidence-based strategies are available, or are being delivered and examined, and our community is very fortunate. I've been able to collaborate with some national experts in this. And so we've seen how we can do this really in primary care settings, unlike some of the other studies that get referenced. And so I think we actually have, especially collaborating with HP, a way to jumpstart this much quicker than colleagues of mine in other institutions, but we need to get that trigger pulled next. And structured supervised weight management, and that's what our interventions have done. That's what family-based treatment does. Actually can decrease and relieve some symptoms of weight and shape concerns and disordered eating. But these type of interventions are pretty specific, and these are not your garden variety. We do wellness, we do healthy eating, lifestyle type stuff. The behavior specialists I've worked with in these studies and have seen the work from others, it's not exactly the same stuff. They talk about role modeling with the children and looking at stimulus control, a number of behavior things that none of us really got much training on, definitely not in any way to use or apply clinically. So it does require us to think of a different team. This is a nice slide just from the standpoint of thinking of obesity being something across a lifespan. It's going to be, at times it may be controlled, at other times may not be as well controlled. And if we are overly focused on weight and diet culture and body image issues, then that's going to make these situations worse. And the critics around obesity will point this out even more, that trying to aggressively address this in ways that don't address shape and weight concerns and mental health will just make this worse. One of the things that I think was really important that AAP did in their writing group, they had experts from a variety of fields, a variety of professions. They also had a family member. So this is Doug Lumsford, who's actually as a parent on the writing group for the clinical practice guidelines. And they have another young woman, Faith Heavens, who's actually a grad student. She underwent bariatric surgery her senior year of high school, went to college at Duke, and is at the University of Florida now studying behavioral intervention science around obesity. And she is a weight advocate as a patient and now as an emerging scientist. And she's a great young woman. So having the voice of the patient and the voice of the patient's family here, I think, is critically important. Obviously, it doesn't represent all patients, but it is represent some. And I think it's important that we have that for those families that do, or are seeking help, and we feel it's the right time and the right blend. So I want to be mindful of time. This slide is very similar to slides you may have seen us present before in terms of looking at BMI percentile, when to look at dressing overweight, obesity, severe obesity. checking labs, because you see here comprehensive history, mental behavioral health screening, social determinants, all that stuff is required all across. And so the reality is if there's lots of issues here, you don't really have to prioritize going much further past this. There are very, very few conditions that are immediately medically urgent in a child with obesity or severe obesity. I can recall a few times we've had kids with such severe sleep apnea, they were falling asleep in the office and turning blue, or the child who might have acute pancreatitis, which might actually be from weight loss from a stone, or the rare case of something like pseudotumor cerebri, because that is potentially threatening of the vision. But the good thing is all those issues, they actually have a proximal medical treatment. Sleep apnea, you can put them on CPAP. We can admit someone for pancreatitis, address that. The intracranial hypertension, we can start treatment for that and not necessarily have to address the weight. So as much as we want to, we actually really have to keep that in mind. We haven't had anything for years here. What's a matter of a few more months as we try to get things set up. So these are additional comorbid conditions that we do have to be aware of. Sleep apnea, obviously, PCOS, and we have maybe a little wiggle room there with some things we can try with that. Depression is really important, and it's bidirectional. Depression can get worse with obesity. Obesity can worsen depression. And if the situation isn't right and treatment, and we had to watch this very close in our study, if we're not watching for depressive symptoms and asking, we could see an exacerbation. And our coaches, because they were all behavioral health specialists, kind of had this in mind, which I think is really critical, because you may slow down some of our steps in our protocol. And we may say, all right, let's not have a meeting next week, let's space it out. And instead of trying to track 3 behaviors, let's just track 1. And understanding what is that stress coming from. Maybe it's coming from the fact that it's holiday coming up and grandma is going to be forcing food down people's throats, because that's what grandmas do sometimes. So IHH is idiopathic intracranial hypertension there, and SCFE and Blount's disease are musculoskeletal problems of the knees and hips. Here is the AAP webpage. This is where a number of resources are. And we will have this in the slide. I want to try to wrap up early to take some questions. So let me just bang through. These are a couple of steps that I think I want you to be able to have and to focus on. I know none of our practices can do this FBT treatment, but if there are small things that you can do that can keep a family engaged, if you see them once a month, every other month, this will be, I think, the intermediate ground of where to go as we build up our intervention team. These 2 studies that we had, we essentially use a similar model of a behavior person that we could embed in the office, and we ran them both during the pandemic, so we flipped them to Zoom. So we actually have a mechanism to really expand this, but we got to build the army and build the bench. So these are some tools. I love this one here, the 5 onlys of eating. This is actually in our toolkit, and I tell families this is a rule for everyone. So only eat in the kitchen or the dining room, only eat while sitting down. Guilty, I walk around the kitchen. Only eat off a plate or out of a bowl, not out of the package. And if they ask, tell them, get little smaller bowls. I mean, if they got like a 4-gallon soup bowl and that's what they have a bowl of cereal for, say, hey, why don't you just try smaller bowls? That's okay. Only eat while you're eating. No screen time. Don't be flipping through your Instagram feed, doing your TikToks there. And only eat if you're hungry, because kids will eat when they're bored. And so if you think about this, this takes away a lot of that mindless eating in front of the screen without being overly restrictive. So just a simple step to try. This is a little bit more on the algorithm. Actually, it's kind of the same thing as the algorithm. And these are some of the bullet points in here. I'm going to blast through these because you've kind of seen them before. It's offering, looking at BMI, height, and weight. I will say that the World Health Organization is looking at, and the scientific field is looking at, do we need to get into better body composition? Are we going to have to look at things like DEXA scans or other things? Because these medicines are so good, we actually have to start looking at, in adults, are we losing muscle mass as well as fat mass? What is happening to bone density and these other things? So we may have to consider looking at something like, is waist circumference going to be useful, or skin calipers, which I hate and I don't think will be useful, but WHO is looking at this. So, this may emerge. So I put in here a little point because everyone's like, it says you should treat them. You should is not must. And so think of should as you should offer. You should try to have the discussion, but have the discussion with those ideas in mind, making sure you've covered the mental health, the social determinants of health things, because you want to address that for your patients, for all your patients, as best you can for whatever condition they do, or, if they don't have a chronic condition. Using a chronic care model means, what tools in your EMR, what resources in your community, like YMCAs or after school programs, and family centered. And that's real important. If, like, doc, we don't want to talk about it, don't talk about it. If they say we don't want to be weighed, or she doesn't want to be weighed, do not push that. That should be your red flag, that there's already significant mental health and stress there that you may have to explore just on a plain mental health side. And please don't think that addressing the obesity is going to cure that mental health issue. Families may think that, but that's really not the case. Should use motivational interviewing. I think a lot of you have seen that and understand that. And the key of motivational interviewing is getting them to just kind of verbalize and discuss. And if we reflect back what it is they're saying, that can be helpful. But it's a step. It's a small tool. And it's a small tool to help move motivation. I think, as I see Daryl on there, the interesting science areas where we can really apply newer behavior principles, not just to change behavior, but to maintain that change. So yeah, I dusted it up here. Given how tough and how tight we are for resources, don't necessarily think or worry. We have to address kids who are even overweight, even at this younger age group. I would honestly suggest that enough of you have seen the simple preventive strategies of things to talk about: screen time, sleep, variety of foods, that don't get into a scale or weight or anything. That's what you want to discuss. When kids get to the 95th percentile, we know there's going to be some excess body fat, but then you have to start, thinking a little differently. And we don't have the resources in the community yet. So yeah, there's my little should, not must. If you leave here tonight and that keeps running in your head, I know will accomplish my job. So let's wait to get something safe and effective in place. And I can't emphasize safe enough, because the one thing we've seen in the study is there's a lot more subclinical mental health stuff that's out there. And there's a lot of shame and denial that families experience that they don't want to tell you. And I've had families, I'm thinking Carol Gagnon, some of the families you had told me about, who came and seemed very enthusiastic, and then they totally ghost us. We can't get in touch with them. We finally reach them. And they're like, no, doc, we really can't do it. And they are afraid to tell you that. So it is super tough. And we're trying to find a better way to allow families to make their way into this place. I'm just thinking some of these practices that were great recruiters, but at the same time, we had families that they were certain were going to come, and it was just not right. So in the right there, I can bring it back: motivational interviewing, intensive lifestyle treatment. I know you all want to know about these last two columns: weight loss, metabolic surgery. These are not a must. These are the rarest of the rare situations, especially right now with the complexity of the payment, the delivery, the coverage of these medications. We haven't had them to use in kids really. We don't need to start them yesterday. We can wait a little bit longer and try to get a better approach to using them. So just not yet. Let's just start with our lifestyle work and see where we can expand that to, also to have medications available when needed. But honestly, we have to start at the top of the mountain. The kids with severe obesity and type 2 diabetes. I mean, I can't even get those drugs through Medicaid. If you call Medicaid right now, they don't even have weight management medications as a class. So, if I can't get these for kids on Medicaid with severe medical conditions, then, we really have to step back. A few shortcuts in terms of things I've mentioned before. Not every patient with a BMI above 95th percentile has disease obesity. I think there's going to be more definitions that emerge. Do we need to almost classify it in a stage system? Like, all right, let's wait till 95th percentile and one or two metabolic problems, maybe a mechanical problem like sleep apnea, asthma, are there mental health problems? And think of it that way, because we can see changes in weight with minimal changes in these biologic measures. And you can see minimal changes in weight, and you can see great social measures. We had one girl who lost about 5 pounds over 2 years, but she went from kind of liking soccer to loving soccer, and gained flexibility and enjoyed school and so much more, and didn't really have significant weight. And as we know, they don't even need to lose weight. If they just slow down or stay stable over 2 years, you're going to see some improvements. Being aware of mental health issues. Please be aware of mental health issues in the family. There's genetic components to this. There's genetic components to mental health as well as eating disorders. And if you have a parent who is kind of really hyper fixated on it, it really is not a bad idea to get a sense of, was there ever any concern of eating disorders or anything as a child? Because if that's the case, that's not really kids that we would try to get into the study until they've already been or studied into an intervention. So we've done it as a study. Even as an intervention, I would want to make sure the mental health and the eating disorder behavior work is kind of tied up first. Let's make sure we don't go over too much. Again, this is in the slide, just looking at some check boxes of things that we make sure we do. And, you know, I know all of you do this. We've been in your offices and charts and stuff, but looking at areas in our community that can help us. And what I mean by that is things that are, they may not be overly effective, but at least they're safe and non-harmful. You know, that may not be easy to find. We're trying to get at least that intermediate list available really quickly. It's not going to be things like Dr. So-and-so on the radio or an aesthetic lifestyle place, because I have gotten calls about those. I've had direct messages sent to me of a friend's family member's daughter went to an aesthetic center, was put on a GLP-1, told not for obesity, but to stop the food noise in her head. Not a pediatrician, and honestly, makes me nuts when I see something like that. It sets back any work we've tried to do by years. So what do we do right now, especially if the intensive health, behavior, lifestyle treatment is not available? What is the best treatment and care? I mean, this is care that we're trying to provide to the children and families who are requesting help, who are really looking for it. We may see a child who's 320 pounds and pre-diabetic. It's not on the radar. I know we're concerned. We just can't, you can't force them. And any further pressure and tension and stress is just actually doing harm potentially. So please don't do harm. Trying to find collaborations in our community for now as we try to build services. I mean, ideally, when we can get a small core of people trained, we can look at disseminating that to people embedded in practices that can be a first line. And if that starts slipping, going to a second line. And I think I'm basically done. I'll leave that slide up here. Just want to show one more thing. These are going to be in the slides. This is data from our plan study that we just published. This was done in Rochester, Buffalo, St. Louis, and Ohio State. We randomized kids, and this is the difference in the treatment arms of kids in terms of the percent weight loss. The bottom is the FBT. The top is usual care. This slide is the parents. Parents in the intervention lost weight. Not a huge amount. Siblings lost weight. This, I think, is really important. These are kids who started and completed the study before the pandemic. These are kids who started and completed a study and the pandemic hit in the last 18 months, and most of the intervention was in the first year. These are kids who kind of, wrong button. The pandemic hit about halfway through their treatment, and you see the weight regain start to cross. And then kids who mostly did the intervention during the pandemic, it overlapped. But the incredible thing is when we pull this together, we see a sustained effect. Given all the damages we've seen from the pandemic, given the fact that this is a behavior intervention without any type of drug therapy, I think it's really encouraging because we delivered this almost entirely with Zoom when we had a flip to that. We had some families who liked in person. So I think we have a community, we have the technology. The fact that the pandemic allows us to use Zoom is a huge bonus. So I'll just stop right now and let LJ go because I know I'm running over.